家，美国宾夕法尼亚州梅多布鲁克斯救世主医院的主治医生。那么他今天给我们讲的这个题目是真空辅助和减针段乳腺癌的基因体验。VAP for diagnosis of breast cancer. Please, Beth DuPree, please.
Thank you. Good morning. I'd like to thank the conference committee for inviting me to speak today on vacuum-assisted biopsies. For most of you, I think you understand what my initials FACS stand for behind my name. The initials ABIHM stand for American Board of Integrative and Holistic Medicine, and I received board certification in integrative medicine as my practice prides itself on combining many Eastern healing modalities such as Reiki and traditional Chinese medicine and acupuncture, along with our standard care for our patients. This slide was initially given to me by Patrick Morgan, who was one of my surgical oncology colleagues in the United States. When I learned how to do sentinel node biopsies in the mid-90s at Memorial Sloan Kettering, Patrick was my instructor for that course. In the year 2005, I had the honor and privilege of teaching Dr. Morgan how to do breast ultrasound as the care for our surgical patients have shifted over the past 25 years. If you look back into the early and late 80s, we were doing all of our diagnostic biopsies in the operating room with open surgical techniques. As the care of breast disease shifted, we began to do stereotactic vacuum-assisted biopsies in approximately 1994 and 1995, and ultrasound vacuum-assisted biopsies began to become our standard procedure in late 99 and the early 2000s. We have moved forward in our care of breast disease and our treatment of breast cancer, and now in the year 2014 we've reached a place in our clinical practice in the United States where vacuum-assisted or core needle biopsy and minimally invasive biopsy has become our standard approach to the diagnosis of breast cancer and often to the treatment of benign breast disease. So where open surgical biopsy was the standard by which I was trained in my surgical residency, once I was in private practice, I had to learn a new technique in order to stay on the cutting edge of how we care for breast cancer. Dr. Lieberman published in Radiologic Clinics of North America in 2000 the clinical study looking at the ability to diagnose breast cancer adequately with minimally invasive biopsies. And that was really a turning point for us in the United States with our breast care. Surgeons and radiologists both perform minimally invasive biopsies, and as a breast surgical specialist, I felt it was very important for me to be able to use my clinical skills to give my patients the state-of-the-art opportunities for their care. In 2005, there was a consensus conference held with multi-specialties including surgical oncology, radiation oncology, medical oncology, and the consensus group came to several conclusions in 2005 which truly shaped the future of how we look at the diagnostics for breast cancer care. What they came out of this conference was a conclusion that minimally invasive breast biopsy is the optimal tissue acquisition method and the procedure of choice for image-detected breast abnormalities. So it wasn't just that it was an option, but that it was the optimal choice. Open surgical biopsies were felt to be those that should be reserved in selected cases, and we should minimize the number of open breast biopsies, particularly for benign breast disease. Also, ultrasound and stereotaxis were our major interventional procedures. We used automated whole breast ultrasound to facilitate screening of ultrasounds. We used ultrasound-guided biopsies to evaluate lymph nodes for patients prior to neoadjuvant chemotherapy. And now we'll place a surgical marker in those lymph nodes so that we can assure that they are removed at the time of definitive surgery. In 2009, the Consensus Conference was held again, and they looked at percutaneous needle biopsy as the best practice, and it truly became the gold standard in our clinical care. Our breast centers of excellence, to receive accreditation from the NAPBC, which is one of our major accrediting organizations for breast care and breast excellence, requires that minimally invasive biopsy be the primary procedure that is performed. And if we do not perform minimally invasive biopsies, we need to document why that was our choice and why we had to return to open surgical biopsy. Definitely there is a difference for the patients in their loss of time to work, and certainly going to the operating room has increased costs for our healthcare system, and it does not allow us to be able to use the information about those tumors for patient treatment. Ultrasound-guided vacuum-assisted biopsy is excellent for small lesions, as with a single insertion device we can get directly underneath the density and allow for very excellent targeting on that lesion. We use it for indeterminate lesions, for heterogeneous lesions, for papillary lesions, spiculated or ill-defined lesions that we believe to be cancer. And from my perspective, taking a patient to the operating room to make a diagnosis cuts out a step in between that I need in order to be able to come up with a care plan for that patient. On minimally invasive biopsy, I'm able to obtain the estrogen, progesterone, and HER2 new status, and this often helps us guide in the patient's care and also allows us to know which patients may be eligible for genetic testing, as triple-negative breast cancers diagnosed under the age of 60, we are sending for genetic testing due to their higher preponderance of BRCA positivity. The handheld vacuum-assisted biopsy device has allowed multiple institutions to be able to do single insertion acquisition with multiple specimens. The single insertion device I certainly prefer myself, just for the ease of diagnosis and for the speed of the procedure, as well as the comfort of the patient. The specimens are contained in one small chamber that can be removed and x-rayed if appropriate if you're suspecting calcifications of an ultrasound lesion. The device actually takes adequate samples. Our pathologists are quite happy with the substance of the samples, and there is a decrease in the upgrade rate from excisional biopsy when the larger pores are obtained. So the advantages that we see for vacuum-assisted biopsies, we use them for staging the axilla prior to neoadjuvant chemotherapy, and also to biopsy potential lymph nodes for nodal recurrence. We also use these smaller devices in patients with breast prosthesis, so that when there is a minimal amount of breast tissue, we can adequately get underneath the lesion and sample it. We also use this information for our neoadjuvant chemotherapy selection, and from a patient comfort perspective, it is an excellent choice. Knowing that someone has cancer on a minimally invasive biopsy allows us to send appropriate patients also for MRI evaluations to rule out multifocal or multicentric disease. Smaller lesions can be missed with core needle firing devices, as the lesion can be pushed distally once the device is fired. Using a vacuum-assisted device, we're able to gently guide the device directly underneath the density and clearly see that we have been able to obtain adequate tissue. I also prefer for biopsying lymph nodes, as I can stay away from the vascular hilum and still obtain adequate specimens. The quality of the pores are something that only our pathologists could truly tell us whether there was a difference. And certainly, I think any pathologist that is making a diagnosis on a corneal device needs to have an adequate sample to be able to make the appropriate diagnosis. When we're doing image-guided biopsies, being able to see the biopsy chamber clearly certainly allows us to be able to know exactly where we are, to be able to see that we are in the appropriate position within two different views, both sagittal and transverse. You can clearly see the biopsy device directly underneath this density, and that way we have knowledge that we are underneath the lesion in the posterior aspect. Intraductal lesions can be easily sampled as well, and the ductal lesions are often difficult for the pathologist if they don't have adequate tissue to determine whether a lesion is papillary or papillary with atypical changes. The vacuum-assisted device allows for the complete image removal of these densities in many cases, which can give the pathologist additional tissue from which to make the diagnosis. Another advantage of vacuum-assisted biopsies is the ability to place a marker at the time of the biopsy in order to know exactly where to return in the event that it is a cancer and image guidance is needed for the procedure. Our patients are very happy with our ultrasound-guided markers, as it prevents the need for needle localization and a separate procedure to be performed prior to going to the operating room. Our surgeons are trained in ultrasound so that we can identify the markers in the operating room and therefore prevent the need for the second procedure. You can see in these pictures the small lesion, which is directly within inside a notch, and in the transverse projection you can see that the lesion is directly underneath the lesion that requires biopsy. For many of these smaller lesions, we may not see any spiculations or any signs of cancer, but it allows us to remove all image evidence of these lesions so that if it is benign, no further treatment may be needed. If it is malignant, then a marker is left and appropriate surgical therapy is determined. One of the things that my partners and I have been very conscious about is where we place our incisions as the surgical treatment for breast cancer continues to change. In the United States, nipple-sparing mastectomies have become the procedure that everyone knows of because of Angelina Jolie, the movie star, having undergone nipple-sparing mastectomies for her BRCA1 positivity. Since that time, the number of patients requesting nipple-sparing mastectomies has increased, so it does make our incision planning even that much more important. When I look at the patient's breast to determine where to place my incision, I'm thinking about the cosmesis for the patient. If we take patients to the operating room for open surgical biopsies, and then they do in turn out to have cancer, we have then created new incisions in which may be a problem from a wound healing capacity. So placement of our biopsy devices is something that we train our surgical oncology fellows to think of when they're doing the biopsies. The periareolar margin heals very nicely and does not necessarily cause a problem from a future perspective with the treatment of breast cancer. Lesions in the upper inner quadrant are easily attained by making periareolar incisions. In the upper outer quadrant, an inframammary incision or periareolar incision can be chosen, and this also allows us to make sure that the patient is comfortable during the biopsy and that the surgeon or the radiologist performing the vacuum-assisted biopsy are comfortable as well. In the outer lower quadrant, there are 3 different options for incision placement, and this very much depends on the size of the patient's breast and the size of the lesion being biopsied. Incisions in the inner lower quadrant, I try to use an inframammary incision as it hides very nicely in an inframammary fold and also allows easy access to the lesion. In multifocal disease, we can oftentimes make a single incision, and with the vacuum-assisted device placed under each lesion at a separate time, we can obtain tissue samples in order to confirm multifocal disease and thereby plan the patient's surgery appropriately, which would clearly be a mastectomy. Thank you for your time and attention.
Thank you, Dr. DuPree.